I have the pleasure of introducing our speaker today. Dr. Suzanne Sysko Clough, MD, is the co-founder and former CMO, or Chief Medical Officer of WellDoc, an award-winning healthcare technology company in the digital health industry. Dr. Clough left her endocrinology and diabetes practice at the University of Maryland School of Medicine in 2006 to co-found WellDoc to address the unmet needs in both patient self-management education and physician clinical decision support. While at WellDoc, Dr. Clough was instrumental in informing the design of the algorithms and the clinical and behavioral architecture of WellDoc's FDA-cleared software platform. Dr. Clough left WellDoc in March of 2016 and co-founded RAS Digital Health, a digital health consulting firm that supports startups and Fortune 500 companies in building out their digital health strategies. So please help me in welcoming Dr. Clough.
Great. What's up, Maryland? Nice to be back on campus. So I was here for 12 years. I did medical school here, residency, fellowship, and then I stayed for a year on faculty. And I left December 31st, 2005. And so what I thought I would do is just share a little bit of that entrepreneurial journey, because I did try to innovate in different ways throughout my time here. And then a little bit about the lessons learned, some of the barriers. Where I got a little nervous was, gee, Suzanne, you left 10 years ago. Is any of this going to be relevant? And so I did share some of the story with some folks who were involved in graduate level entrepreneurship programs. Like, yeah, trust me, sister, it's not all worked out yet. So I'm hoping some of it's relevant. I'm also hoping, for the sake of this place that I love so much, that some of it's been worked out. And then I kind of want to map those lessons learned or barriers back to a bigger picture of, what does this mean for institutional culture that really could foster innovation and entrepreneurship and intrapreneurship. So with that said, all right, so the title of my talk, and this is pretty much the only slide that addresses that, is, I wanted to impress the need to have entrepreneurship in graduate studies, especially the life sciences. And I'm going to be a little selfish and just really focus on the medical path, because that's what I know. And just for my clarification, is anybody here in medical school or a resident or fellow? Okay, so one. Not really speaking to the crowd here, but I'll try to make it generalizable. So in medicine right now, it's an incredibly exciting time. It is, I think, unlike no other time in medicine. Things are changing at such a pace, it's almost mind-blowing. And I put up here just to kind of root everybody in some of these macro system changes of, why we have to do more for students than just the day in, day out curriculum. We have to get people not only to be better critical thinkers, but we have to help them innovate to solve day-to-day business problems just to stay afloat, especially in medicine. But there's the big piece here in the bottom left-hand corner is this Medicare Access and Chip Reauthorization Act that was passed in 2015 by the government, and it looks like the new health HHS head, Tom Price, is going to keep this in place. This was a highly bipartisan piece of legislation, but what this does is it turns medicine upside down. We are finally going from what has been referred to as volume-based care. So doctors would see as many patients as they could in the day. We would bill for that service, so fee for service, kind of eat what you kill type of thing. And let the cards fall where they may. We had no idea if what we were doing was actually helping people from a population perspective. Well, what MACRA says is, no more. Now we're going to switch to value-based care. And what MACRA also did is it was the government recognizing that they kind of effed up along the way too, with the regulations they put on us, with meaningful use, that we had to, all these computer buttons we had to click instead of looking in the eyes of our patients. So they said, okay, look, let's do this together. Let's go a little bit slower and let's figure out how to innovate the entire healthcare system, business as usual, and we're going to start looking at outcomes. We're going to start paying you for value. So that's a big change. And so that's on the public side. And I'll tell you that on the private, the Blue Crosses and Blue Shields of the world, the Aetnas, they're there too. About 50% of their contracting now is on this value-based care. So think about this as a doctor. When I came in residency or even med school or fellowship, nobody talked about the business of medicine. It was almost like a dirty thing, like, we're here to heal, we're doctors, we don't talk about that. We need to talk about that because you have to stay afloat. You can't be a good doctor if you can't run a business. It's kind of important. So especially now. So one of the big pieces with MACRA is we're also kind of getting away from this autocratic paradigm of medicine. I'm the doctor, you'll do it as I say. And doctors and systems are really now truly being monetarily incentivized to put the patient in the middle. We've talked about it in the center. We've talked about it for years, but it's always just been stuff we talked about. Now, patient satisfaction is going to be a metric of whether and how much you get paid, what your bonus is going to be. And I can tell you that in med school, in residency, in fellowship, no one's telling me how to do all this. No one was teaching me on, well, what is the best way to give emotional support when I have 6 minutes in an office with somebody? Should I bring in digital health tools to help extend my care, extend my support? Patients' preferences. Well, we're taught on population guidelines. How am I supposed to do all of this? So there's a lot to be learned, and we doctors, there isn't a lot of time in the real world. So you can imagine that with things like MACRA and value-based cares, doctors are going to have to get really innovative in their practice. It's going to have to be more than them. What do they build from a support infrastructure standpoint to help extend their care when that patient walks out of the door and on their own for the 8,700 hours that they're out there living with their disease away from their healthcare team. And then this next box just wants me to bring up, or reminds me to bring up with you where we're going with data and big data. I mean, truly in medicine, up until recently, we had no idea how we were doing on a population level. I could come in and see you, I'd pull out your chart, I could see how you're doing, but that was a one-on-one basis. And now that's all changing. Hospitals are getting smarter about the data they're collecting. They're getting smarter about the physicians they hire. They're using their data to feed back to their physicians, like, hey, you want to stay employed? You need to cut your costs and improve your outcomes. So data is really driving the day-to-day way that hospitals run, physicians practice, very important. And then, near and dear to my heart is sort of this digital health revolution. And digital health really is a waste bucket term for anything to, one-way SMS text messaging to fully robust telemedicine and telemedicine services. And it's not just the technology, it's everything, the data that the technology is pulling in and what we can offer. It's bringing in genomic information. It's getting passive data. It's pulling from open source APIs, the social determinants of health. So now I am not only going to calculate a risk score for somebody based on claims data, but I want to know, are they impactable? If I have an intervention for a high-risk person, how do I know this is an intervention that's going to impact this person? Well, medicine is evolving that we're not just looking at objective data. Believe it or not, the patient has important things to say about themselves. That the patient, it's no longer just good enough to know, are you married? I want to know, what's your marriage like? Do you go home and just freaking hate your husband? Because that's a big, important piece of information. When I put that into my algorithm, I'm going to understand that your support system is not what I think it is, and that could actually play a big role in your ability to self-master self-education. So anyway, there is so much going on, and it's going so quick. And what I implore universities is, as physicians, as biologists, as behaviorists, we got to be in on this. We can't let technologists build technology just for the sake of building technology, because it never works. It doesn't integrate into our workflow. So there has to be a marriage of technology and the background that folks in life sciences have. But again, it means that people have to walk out of these walls knowing it exists and with the skills and knowledge of being able to jump in and get in the mix and play a vital role. Okay, here's the other reason why this is so important. A couple of years ago, the Wall Street Journal surveyed 12,000 physicians, and only 6% reported a good morale with their job. 6%. when I was at WellDoc, when we were first trying to commercialize our diabetes product, I would go door to door to door to physicians and explain to them why they should have it in their practice. And by the end of it, I wanted to poke my eyes out. It was the most depressing thing. EMRs have tanked people's quality of life. The reporting has tanked quality of life. You come out of med school with $1 gazillion of debt and your reimbursement's going like this, and then you're feeling not connected to your fellow human who's sitting across from you. So there's a real need for us to equip people that are taking care of other people with tools to try to get this up, instead of just sitting there and slugging through the motions and just accepting what's being thrown at you. Can we give people the tools to say, time out? I put a lot of money and a lot of time into becoming, having this career. I want to do it. How do I make it work for me? So, I'm going to just step through a few of these things and talk about a little bit of the barriers, and I'm hoping a few of them are still relevant, so I'm not completely outdated and this isn't a total waste of your time. But I want to start right before I went to med school, and I got accepted and then deferred because I was starting the Delaware branch of a leadership development program for young people called Public Allies. And why I want to share this story is because it's who I was when I entered med school. And here I was in the community in Wilmington, Delaware, working. I was 21 years old. I was super passionate. I was completely naive. I'd look up foundations and like, oh, this guy, let me call him at home on a Sunday and see if, he'll fund my project. It was just doing things because I believed in it, and I didn't have any, formal skills, and neither did the other young people around me. We just pushed through and we got things done, and it was so exciting. We had such a great story to tell, and people bought it. And I left that 2 years and I came into med school ready to change the world. I saw what grit, passion, perseverance, and a community of like-minded people could do. And so I got to med school and I was like, all right, that didn't last long. Yeah, so what happened was, I got to med school and we did the first 2 years, those are in the classroom, and then I get on the wards. I was like, why was nobody talking about the obesity epidemic and how it's actually manifesting here on the wards? Like, why are we just throwing pills at hypertension, cardiovascular disease, congestive heart failure, diabetes, et cetera? And it was just so maddening because it was a time of sick care. Hospitals made money from sick care. And I had all this passion. I was so fired up. And there was nothing to anchor into to say, okay, let's huddle. Let's go in this co-working space and go figure out what we can do. And let's have this faculty mentor, help us figure out where to start and what story we could be to get put together that would be compelling to the department. It just didn't exist. There was no infrastructure for people who could identify a problem than to do something about it outside the traditional walls of the healthcare system or outside the walls of sick care. So that's when I kind of tanked and I was like, all right, well, look, let me just get through med school, and then maybe when I'm a real doctor, I can do something. So med school came and went, and then internal medicine residency came, and that was even more of a shock because now you're really on the wards, you're really in the clinics, and you just see these people who are so sick, and we're not fixing the root problem, we're fixing the symptoms. And I hated it. I just hated it. And so I talked to my chairman about it, Bill Henridge at the time, amazing man, and he's like, well, quit griping and go figure out, what other hospitals are doing about it. I was like, all right. So I looked around and I found Akron General Medical School, or Akron General Wellness Center. It was in Ohio, and they had built this 30,000 square foot, multidisciplinary, medically based wellness center that had everything you can imagine in it. And it was just, the website was people just, it changed my life, it saved my life. I'm like, this is it. So I called them like, hey, I want to come see you. Like, no problem. It'll be $1,500 for half the day. I was like, all right, I am dirt poor, medicine resident, not happening. But if you'll just take a step back from the entrepreneurship side and how they were doing things differently, they knew, they could see ahead far enough that wellness had to be in the mix of care. They also knew that wellness wasn't going to get traditionally reimbursed. So they came up with one innovative business model is, let's let the world know how great we are, and let's essentially make a consulting business out of it. So they would charge $1,500 to $3,000 for a group to come on, and then people would know that they really didn't have the infrastructure back at their campus to do it, and they would hire them as consultants to help them. So it was just to throw out there are ways to think out of the box to say, look, we need to make money. This thing has to make revenue. How can we do it? And that was, I thought, a very clever angle. So I just started then asking around, who does wellness here at Maryland, the VA? I found Andy Goldberg's group over the VA, found the neurology group, and a couple of us we networked. So we talked maybe a couple hours a month. I ran with one guy. We would talk about things. We had nothing formal, but we knew we were all passionate about it. And luckily, the neurology department decided to foot the bill for us to go out to Akron. And in the real world, it was just as amazing as it was on the website. So we all came back fired up, and I went and saw Dr. Henridge, and I was just flabbergasted that his answer was not, yes, we need to go build this. And he's like, Suzanne, we need to convince the dean this is something to even consider. He's like, you have no economics, you have no plan, you don't even know where you'd build it, you don't know if people would come. So, for him, he was a champion. He said, look, I'll give you my administrator, Pat Bro. He'll help you with the business plan. I went to my residency director, and she said, I'll give you like 2 weeks in this 1 month elective, pull it together, and let's see what we can do. So you can imagine, with someone who has no business background, I had 2 weeks and a little bit of time of a very busy administrator. It was the worst business plan on the planet. But I still thought it captured the essence of how amazing this thing could be. And Dr. Henridge, who was just so great, he said, this is not a good business plan, but I think there's enough here that we could at least take you to the dean, and he may say, I'll give you guys a little bit of money to pull a team in to do a business plan. So I was feeling pretty good, and I went in there, and he was the meanest man in the world. He's gone. And he wasn't really mean. He just laughed at me and was like, sister, we gotta make money. Like, you don't have 1 ounce of any credibility on this piece of paper that would convince me we need to build this. So I cried because I was very frustrated at this point. I'm like, if the dean shut me down, like, where do we go now? And then later, as a side note, Dr. Henridge told me, don't ever cry in a meeting again. And I have not since cried in a meeting again. But my tears were really just this feeling of frustration that I knew I didn't have the skills I needed. I knew I didn't have the knowledge set. I knew this man, this mean dean, was right, that I had to be able to tell the story. I had to show hard economic outcomes, hard health outcomes. This is a business. And even though I'd gone through all my training with nobody wanting to talk to me that it's a business, the guys that are up here and the women that are up here know it's a business. And so I think, my silly little tears that day were really just feeling sorry for myself that I was stuck, that I didn't have the tools in place to tell a compelling enough story. So I'm almost done about this little journey. So the Wellness Center didn't get built, but then I got offered an endocrinology fellowship, and I thought, okay, this is good. This is how I'm going to deal with the obesity epidemic. And I went through training. It was amazing. And at the end, they said, okay, you can stay on as faculty, and you'll be the medical director for the Center for Weight Management and Wellness. And again, my vision was wellness. Let's do a holistic, comprehensive behavioral therapy, exercise therapy, And the university's like, oh, that's so cute, but no, we want to do bariatric surgery. And which I think is good, and I think it's a good tool. I personally just didn't want to triage for bariatric surgery, so that didn't last. So at this point, I'm kind of wondering where my career at Maryland's going. I loved being here. And then one day, this kid knocked on my door, because I'd also started the Get Fit Maryland program, the 10,000 Steps program. It was a public-private initiative that we ran statewide to get people moving with pedometers. And this pediatric fellow, Eve Nordman, came to me, and I won't even try to do his accent. He's from Switzerland. But he was always so excited, like his shirt was hanging out and his hair was up. He's like, I have this great idea. He's like, we can use cell phones to do obesity. Now, this is 2004, okay? This kid was so forward thinking. There was no smartphone. People talked on the phone, yeah? And data plans were like prohibitively expensive. But he was so excited and passionate. He sold me on the vision. I was like, oh, I get it. And we talked about it. And I was like, but where do you find, he was also an Orthodox Jew. And I said, well, where would you find a cell phone programmer? He's like, I'm an Orthodox Jew. I know all the other Jews here in Baltimore. And he's like, and there's one. So we did. We found this guy who was like the only programmer, I think maybe on the East Coast at that time. And we came up with a little beta version and tested it, and it was all exciting. And so then we said, okay, well, we talked to our mentors, and they said, okay, well, you guys have to go talk to the lawyers at university and have to go through the whole IP process. That was awful. It was so bad. I mean, I walked in there again, pretty naive, just thinking, I love this institution. Like, this is so great. They're going to be so happy to see us walk in with these amazing ideas. And it was just not at all what I envisioned. It was completely not in the spirit of collaboration. And there was no incentive for us to keep working on this, because it felt like you're going to do all this for us. There's no support for you. And again, all these people are gone, so I can pop off. They're not here. So, yeah. So at that point, I was like, I feel like God speaks in ways through little angels, right? And the little angels can be really good things or things that are, just doinking you on the head. And so at this point, I'm like, I gotta go. Like, I have this amazing training, right? I had this amazing medical training. I thought I was a really good doctor, but something was telling me you want to do something else. And then my little angel Eve came in with the cell phone technology. And then my angel, Stuart Greenenbaum, the Greenenbaum Cancer Center, he was a patient of mine. He said, well, we should do this for diabetes. And he essentially, the poetic version of it was wrote a check and said, go start this company. So, I'm about to leave, and I can't tell you how many of my attendings, not my boss, Alan Schuldiner, he was great, but so many attendings and colleagues, they tried to shame me. They were like, this is academic medicine, or this is career suicide. I'm like waking up in a sweat, because that's all I'd known for 12 years. I'm like, oh, they're right. What am I doing? And so what I said was, I couched it, and don't do this, just leave. But what I couched it was, look, all right, I'm not really leaving. I'm going to go for 6 months, but I'm sure I'll be back. And that was, 12 years ago. I didn't come back. So that was the story. And I left. And I have to share this with you. It's really funny. So there's a whole deck on this. You have to Google this woman's name. Her name is Tara Hunt. But I didn't put it all in there because the F-bombs on every other slide, and I figured that wouldn't be appropriate. But you can go find it. But so this was my life for the last 10 years. And this is, again, Tara Hunt. She's the founder of something, it was called Biosphere. And she wrote it when she was starting it up, and she did this presentation in 2011, and then she went out of business in 2014. I mean, that's the life of a startup. But I just thought this was funny. Monday, Tuesday, Wednesday, feeling good. Oh, Thursday, Friday, Saturday. Let's start over. Yeah. So I put this in here to kind of remind me, too, that I'm not suggesting that everybody is an entrepreneur with respect to going and leaving and doing a startup. The world doesn't need a million of those people. And it really takes, I think, a certain DNA to do it. But this world does need people who are willing to want to make change inside as well. I mean, it's so important we make change here. So again, I just want to caveat, I'm not saying everybody leave and go do a startup, but it's, even if you stay inside, it's hard, right? And so I hope your white paper figures out, well, how do you then create the institutional culture where it's okay for it to be hard, and you're going to be supported, and you work hard, but that you have the lifeline or the extension and the support to see something from beginning to end. But also, I was thinking about this, is that not everything's going to end when you're done, and not everybody wants to stay. So how do you set up seamless transfer of one idea that's really gotten traction and is good, and then the next group can come and take it? I think one of the biggest problems that institutions make, and pharma does this like you wouldn't believe, is they put in unrealistic expectations for the life cycle of the creation of these things. I mean, I started WellDoc in 2005. We had to do clinical trials for 3 years. We had to go to the FDA. We didn't even start talking about the commercialization, the real world commercialization, until about 2010. No, I lie. What year is this? 2017? Till like 2013. So that's a lot of time. So yeah, that's just something to think about, that whatever gets in place really needs to be able to support something longitudinally and give a project that has merit the ability to breathe and live.